Ashok Rupade, consultant rhinologist and skull-base surgeon from University Hospital Southampton in the UK, and also from Hampshire Hospital NHS Trust from Winchester. I have with me my colleague, Ms. Louise Melia. So Louise is a consultant rhinologist and skull-base surgeon from University Hospital Glasgow in Scotland. So welcome, Louise, and thank you for joining us today to help us hosting this very exciting day.
No problem at all, Ashok.
On behalf of Scientific Committee of Global Rhinology Network, I welcome colleagues from all around the world to this very interesting event ahead. So we got 2 days of exciting sinus, endoscopic, and skull-base surgery. We'll have various experts from all around the world performing live surgeries for our delegates. This is our 6th such event. So far, our events have been very well received by our global delegates. So around 50,000 surgeons have benefited from more than 120 countries. So we started in 2014 in association with Lion Foundation, which have established tradition of delivering such event in the otology section. So Dr. Rob Evanson and Wilco Grolman, Mr. John Oates of Lion Foundation have helped us to establish this event. And further, like-minded surgeons have come together, and we have developed this platform for our delegates. So Louise, the aim of our foundation is to deliver the professional education to our global audience from the best of our faculty, and they get free access for this. And this initiative is supported by Medtronic and Karl Storz and our various industry partners. Without their support, such initiative is not really possible. So far, we have developed such live surgical events. So, apart from this, we have developed some book review. Then other initiative was a research day. So the research day in December last year was also very well received. Then we are also recently held an event which involved visiting the centers of excellence around the world. And we visited the Groote Hospital in Cape Town, South Africa. And going further, we'll be visiting some more centers and bringing you some interesting and exciting events and news from rhinology world. So without further ado, we will be joining our first center as Professor Dr. T.N. Jankiram, a very famous surgeon from India. He practices in Trichy. So he'll be joining us, and he will be staying with us all throughout the day. So the first case, very interesting case with CRS with nasal polyposis. So can't wait further to join Trichy. So before we get there, we'll be playing some Medtronic and Karl Storz informational videos. And after that, straight over to Trichy to join Dr. Jankiram. Thank you.
We know the world we live in changes drastically, faster than ever before. We are aware of the threat of the environmental crisis as well as the social inflection. Priorities and consumer values change radically. We have reacted. We have initiated major changes already, with many more ahead. Not to survive, but to keep our business ahead in this disruptive world. We have pulled the switch to green power. We have already significantly reduced our global carbon footprint. And we will continue to do so. With energy targets clearly defined, our monitoring systems perfectly control and enhance our energy targets. The integrated water cycle concept of our new production and logistics site in Neuhausen will save about 10 million liters of water every year. Enough to cover the consumption of a city with a population of 78,000 for one whole year. We are planning well ahead for a sustainable future. Our new site in Neuhausen will be as close to carbon neutral as can be. Reusing excess production process heat, modern waste disposal management, PV systems for generating renewable electricity, recirculated wastewater, and an optimized transport system add up to the best resource management possible. Let's shape a sustainable future together.
The head and neck surgeries you perform are vital. Your patients place their trust in you. You help them continue to speak and smile, eat and drink, hear and comfort. You're committed to helping them continue to live fully, to feel deeply, and to enjoy the quality of life they've come to expect. That means being confident that you're protecting and preserving your patient's head and neck nerve function during procedures. Introducing NIM Vital, the next generation of nerve monitoring technology. NIM Vital provides advanced nerve monitoring that helps you reduce the risk of nerve damage during head and neck procedures. Detailed intraoperative nerve condition information helps inspire your surgical strategy. An intuitive user interface with a wire-free patient interface allows for easy setup and enhanced visualization from the surgical field. Real-time notifications of nerve conditions, visually and audibly. Green, yellow, and red status bars provide visual information, and their associated tones provide audible cues, making monitoring function easier than ever. NIM Nerve Trend EMG reporting enables nerve condition tracking throughout a procedure, even when using intermittent nerve monitoring. And when paired with a NIM continuous monitoring electrode, you have continuous nerve monitoring informing your surgical strategy. NIM Vital pushes the boundaries of monitoring nerve function in various procedures in head and neck surgery, with real-time information available during surgery, giving you confidence in nerve function. Because protecting patients' nerves and senses is more than vital. NIM Vital.
Short break. We're back in the studio again, and we'll be joining over to Dr. Jankiram in Trichy in India. So over to Trichy.
Okay, so a very good morning to all of you. I'm Dr. Jankiram from the Royal Pearl Group of Hospitals, India. And I first of all thank Professor Ashok and Professor Lucy for having included me in this very prestigious workshop that is done by the GRN. GRESS live workshop is always special for me because I keep watching it every year, and it's basically to propagate knowledge. Without much ado, we have a big lineup of cases the whole day. And I will hand over the mic to Dr. Monica, who is going to brief you about this case.
Okay, welcome, Dr. Jankiram. So it's a great privilege to have you on board with the GRN Live Surgery.
Thank you, sir.
Please. Sure. Good morning, everyone. I'm Dr. Maunika, fellow at Royal Pearl Hospitals. Royal Pearl Hospitals is the largest chain of ENT hospitals in India with branches at Trichy, Hyderabad, and Chennai. Coming to the first case, we are going to demonstrate today for live international endoscopic sinus and skull-base surgery is multiple polyposis. 25-year-old female presented to our OPD outpatient department with a history of bilateral nasal obstruction since 5 years. History of headache and history of smell disturbances was present, and history of recurrent sneezing is also present. No history of nasal bleeding, no history of visual disturbances, and no history of difficulty in swallowing. Coming to the past history, she is a known case of bronchial asthma and no comorbidities. Coming to the examination findings, deviated nasal septum to the left and bilateral polypoidal tissues are present. Oral cavity, no abnormality, and in oropharynx, bilateral grade 2 tonsillar hypertrophy was present. Ear bilateral tympanic membrane intact on video laryngoscopy within normal limits. I would like to hand over mic to Janikram sir for detailed discussion of CT paranasal sinuses.
Yeah. History from Dr. Monica. Now I'm going to read the scans and I'm going to tell, this is basically for the juniors, how to read a scan of the paranasal sinuses. Well, let us understand that there are two ways. Number one is a soft copy, second is a hard copy. I use both, but in this case, I want to show it with a hard copy. And it's better to have all the three cuts, the coronal, the sagittal, and the axial cuts. However, I think in developing countries where, you know, there are 4-slice, 6-slice CTs and things like that, it's always better if you can project your brain with a coronal cut and get the Isar axis so that you have a complete overall knowledge of the whole scenario with just the coronal cut. So I'm going to show you how we hardly use the navigation in our center for sinus surgery. In fact, even for skull base, we very, very hardly use navigation, though we have it, but we generally don't use it. Let's now go on to reading the scans. I always teach my residents how to read a scan. And I always tell them that you have to read the scan two times. Never read the scan for the pathology. The scan is for the anatomy. That is very, very important. The scan is for the anatomy and not for the pathology. So let us start with the first cut. Are you able to see the first cut, Dr. Ashok?
Yes, yeah, you can see.
Okay, just zoom it, please. Yeah. So this cut on the top left corner always should be there in a good scan. And that's called the gantry view or the scout view. And it gives the position of the patient, how the patient has been positioned during the scan. And it also gives the slice thickness. Sometimes, if the patient has got a frontal sinus disease, then I ask for very, very thin slices at the frontal sinus and maybe some thick slices at the... So basically, I always believe that we should have at least a 2 or a 3 mm cut if we want to have a complete detailing of all the anatomical structures, including the cells around the frontal recess. So I think a 2 mm cut. Sometimes we get scans with 5 mm cuts or 7 or 8. I don't like that. We definitely need at least a 2 or a 3 mm cut. So let us start reading the scan. I want to tell you that read only the anatomy first. So let us start here. The frontal sinus is on both sides. And you can see that the nasal bones and the ascending process of the maxilla coming up. First of all, your eye should go towards the septum, the cartilaginous septum, whether it's deviated or not, so that we should understand whether we have to operate and do a septal correction or not. So I'm reading on the septum. The septum is already started moving towards the left side. So there's a septal deviation here. And you can see here that the frontal sinuses are very well developed. So that's the most important thing. The next cat, what you're seeing is a small cell here, and that's the interfrontal cell. So that's the interfrontal septal cell. Please understand that the interfrontal septal cell always opens into one frontal recess. So always trace that cell and see where it is opening into. So if you see this cell, so once you see this cell, trace the cell and it's opening here, maybe into the right frontal sinus. So that's very clear. So the interfrontal cell, if it opens into that frontal sinus, the frontal drainage pathway of that particular, the side of the frontal will be pushed laterally. This is basic mathematics. So this is always to be understood that if the interfrontal cell is big and it opens into one frontal recess, then that drainage pathway will be shifted laterally. So this is very important. So that's the interfrontal sinus septal cell, and it's opening into the right frontal sinus. Okay, fine. Now, how do you say it's the frontal sinus? How do you say it's the frontal recess? Let's understand that as frontal sinus surgeons, we don't operate on the sinus. We operate on the recess. So how do you know it's the recess? So that's what I call as the M sign or the T sign. What is the M sign or the T sign? Let us look at it. See here. If that's the ascending process of maxilla, that's a perpendicular plate of ethmoid. So you have a connection between both. You can see that that's connected. So it looks like a M. You can see here that M. It's like an M. Of course, I have not published it, but that's how I teach my fellows. So this is actually the M. And when the M is lost, you can see here, the M is lost here. So there is a small M here, just there's a little nasofrontal beak, and this is actually the nasofrontal beak. So the M is lost here. If the M is lost, then that is the start of the frontal recess. So the loss of the M sign or the T sign, we call it the T or the M sign, that's the T sign, or the M sign, if it's lost, then the frontal sinus transits on to the frontal recess. So this is point number one. So your frontal recess starts here. So when you do a frontal recess surgery, always look at the medial lateral distance as well as the anterior posterior distance. So you should know the boundaries of the frontal recess. What are the boundaries? The medial is bounded by the middle turbinate, laterally by the lamina papyracea, anteriorly by the nasofrontal beak, and posteriorly by the anterior ethmoidal artery. So you should be able to open and show all the four anatomical structures. And if you have not shown the four structures, you have not done a full, complete frontal recess surgery. And frontal recess surgery is an all or none phenomenon. You cannot just open just that area of the frontal recess and just leave the, the fovea there behind. So you have to show me the nasofrontal beak in front and posteriorly the anterior ethmoidal artery in every case if it's involved. Right, here we are. So I'm going to read the anatomy of the frontal recess. So here we are, you have an Agenazzi cell. So Agenazzi cell is the first cell to appear. I'm going to operate only on the right side because the left side, I'm going to demonstrate a lot of cases. So I'm just going to show you only the right side. So concentrate on the right side, inferior turbinate. The Agenazzi cell is here. The Agenazzi cell is here. And if you look at here, you can see here, there is a quadrilateral prolongation of the inframedial wall of the orbit. And that is the nasolacrimal duct. So that's the nasolacrimal duct. Always understand that's the nasolacrimal duct. And that nasolacrimal duct, after this, will be the uncinate process. You can see the uncinate process after this. Don't search the uncinate process before that. It's not possible to find it. So you can see that this is actually the Agenazzi cell. And there's a small spicular bone. That's the middle turbinate. That's the middle turbinate. And you can see here that this is the uncinate process going towards the skull base here. And you can also see a little bit of that uncinate process going towards the middle turbinate as well. So there's a little forking of the uncinate process. And if you look behind it, you can see the suprabular cell. So behind the uncinate will be the bulla, right? So above the bulla, you have the suprabular cell. So what is the difference between a suprabular cell and a frontal bular cell? A suprabular cell never extends into the frontal sinus. So it stops short of the, that is seen very clearly in the sagittal cut. And this is a suprabular cell, very, very clearly seen. And you see here, that's a suprabular cell, that's a bulla, that's a middle turbinate here very clearly. And now coming to the maxillary sinus. You can see here the maxillary sinus, very well developed. And here you have to look for the horizontal attachment of the Uncinate process. You see here, that's the horizontal attachment of the Uncinate process. You can see very beautifully, there's a little curvature here. I have to remove the horizontal part of the Uncinate process. And you can also see a small, a cell which is going here, which could be a Haller cell. I'm not very sure, but we will look at it when we are operating. But I will be very, very particular to search for this particular cell there. Okay, fine. And after that, the next you have to see is the anterior ethmoidal artery. See here, this, you will always have a supromedial prolongation of the orbit. You see here very, very clearly. Can you see that? This is the anterior ethmoidal artery, which is dehiscent in this case. That means there is a supraorbital pneumatization. So if there is a supraorbital pneumatization, you will have the anterior ethmoidal artery, which is dehiscent. And if it's dehiscent, it can run in a mesentery, and you should be very careful when you operate there. And if you should not pull it, if it pulls, it will go inside the orbit and cause orbital hematoma. So that's something which is very, very important to know. And it goes between the medial rectus and the superior oblique muscle, and the artery travels like this intracranially again. Now, coming to, at this level, you also look for the Kiros classification. Kiros 1, Kiros 2, and Kiros 3. You can see here, this is a sort of a Kiros 1, 2. It is more or less a type 1 Kiros. That's a kind of skull base. And then this is the anterior ethmoidal artery. And behind the anterior ethmoidal artery, you can see that these are the cells which are growing more rectangular, and these are all the posterior ethmoidal cells. These are all the posterior ethmoidal cells. And always look for, when you look for the posterior ethmoidal cells, you look for the sphenoid sinus, the anterior wall, and you look for any, a prolongation of the supramedial wall of the orbit here. You might find the posterior ethmoidal artery also. No, I don't find the posterior ethmoidal artery. This is the anterior ethmoidal artery. This is the level of the posterior ethmoidal artery. But here, what is it here? There's a prolongation here. See here. There is a prolongation here in between the anterior ethmoidal artery and the posterior ethmoidal artery region. So this could be the middle ethmoidal artery. So as you can see the paper which has been published by Professor Karau, Ricardo Karau, who says that there can be the presence of a middle ethmoidal artery in 13 to 36% of cases. And you can see that's the middle ethmoidal artery, very, very clearly seen. So you have the anterior ethmoidal artery, the middle ethmoidal artery, the posterior ethmoidal artery is not very prominent. Okay, as we go behind, you also, where you follow the orbit, and you can see that there is a small cell here. Just, that's a sphenoid sinus. And just in front, there's a small cell. Maybe it's a posterior most ethmoid cell or an Onodi cell. There's a pneumatization of the rostrum of the sphenoid. And that's actually the beautiful sphenoid sinus, a smaller sphenoid. You have a dominant and a non-dominant sphenoid. And here the right sphenoid is non-dominant. The left sphenoid is dominant. And you can see two canals here. This canal is the Vedian canal, and this is the V2, canal for the V2. You have a little lateral recess here. You can see here that posterior, you can find a beautiful lateral recess. If you draw a line like this is called the VR line, and anything lateral to it is the lateral recess. So you can see here that this is the sphenoid sinus. Now, having read that, after that, you can go behind if you want. If you're a skull-based surgeon, you can go behind. Look at the foramen ovale. This is the foramen ovale. You can see that all that is, for skull base. I'm now going to deal with this patient. Now read the pathology. Now, when I look at it, I don't have an MRI for this patient, but this seems to be the frontal is involved, and you have an interfrontal cell which drains the right frontal sinus. I have to open up the frontal. I have to open up the ethmoids. I have to open up the maxilla. I have to open up the posterior ethmoids. I have to open up the sphenoid sinus as well. So the only carry-home message in reading this is do not read pathology. Read anatomy. Read anatomy. You can use a software. You can use a soft copy. Do whatever. But you should have a 3D picture of what you're going to do when you start the surgery. With this briefing, I'm going to start my surgery right away. And the expected time duration will be around 30 minutes for 25 to 30 minutes for one side. I'll keep explaining. Professor Ashok can ask questions, and we'll make it like a discussion.